Thanks very much, Vic, and thanks for everyone coming today. As Vic said, I'm going to be talking about, I think, I suppose with the recent election, where there's a Royal Commission coming, and, we've had recommissioning, we've had a big investment in the last couple of years in the alcohol and drug sector, and I suppose with all this investment, a key critical question for government is, how do we use this money in a way that is of greatest benefit to the community and the users and families who come through those systems. So the big question for government is really about how do we design an effective alcohol and drug system. As Vic said, I'm going to be drawing a lot on this report that we were commissioned by the department to put together last year in terms of developing a planning model around thinking about alcohol and drug service provision in Victoria. So this report's freely downloadable from the Turning Point website. So if you want to have something to read tonight when you're bored before bed, help you a bit get to sleep, then please download and have a read. So a lot of the information I'm going to present is in there. And I think, and also there's a lot of information, I think, in terms of sort of what we've learned over the last few years in this system. So the key questions we were asked, by government, and what I'm going to talk about is, key questions are, first of all, does treatment work? Should we get up and come to work? Does it work? And if so, which bits of the treatment system, which are the elements that have the best evidence? The second thing is, if treatment does work, what are the factors both in the people who access the services and the way the services are designed in terms of thinking about what influences treatment outcomes? From that, then, if we know which elements of the treatment system work and we know what influences treatment outcomes, how do we design a system that takes account for that? And then, once we've designed that system, how do we decide who gets what? How do we allocate resources to decide what different levels of treatment different people should be provided at a point in time? So in terms of resourcing, in terms of how we fund that, and then how do we bring this together to create, really at a population health level, a candidate model to test for government. So they're the sort of areas I'm going to cover, but it's largely what I'm going to present today is, what is the state of the evidence in terms of what we know and don't know about the treatment system? So first question, does treatment work? So there's been 3 major treatment outcome studies in Australia. The first was conducted quite a few years ago now, almost 20 years ago, by NDOC, recruiting almost 750 heroin users from 38 different agencies across Sydney, Melbourne, and Adelaide, recruited through pharmacotherapy, so people on opiate substitution, pharmacotherapy, for resi rehab or withdrawal, and then 80 heroin users who weren't in treatment. So just to compare the differences in outcomes between those in and not in treatment. So the good news is that those who were in treatment, they were managed to reduce their use over 12 months from 99% using heavily at baseline to around 40% at 12-month follow-up, with further reduction sustained over the next few years. That was also associated with reductions in other benefits in terms of health and well-being, in terms of criminal involvement, injection-related health problems, mental health, physical health improvements. And when you looked at what were the sort of predictors of positive outcomes in over that 1 year, particularly in this group, so obviously spending more time in pharmacotherapy, so being on opiate substitution treatment, we know is a really good way of stabilising people. People who spent more time in a residential rehab setting had better outcomes at 1 year. People had the greatest number of cumulative treatment days over that one period. So the amount of dose they got, so how much treatment they actually received, was a good predictor of outcomes. And the final one, which I'll come back to quite a bit, is fewer treatment episodes undertaken that time. So this issue of treatment stability. So rather than having fragmented care where people come into treatment lots and lots of times because they rebounding out of treatment, if we can try and keep people in treatment, in a treatment episode for a longer period, that's associated, that continuity of care really is associated with much better outcomes. And they recently did a few years ago an 11-year follow-up of this sample, and they showed that benefits still continued, and being engaged with treatment, particularly this treatment stability, this continuity of care, was associated with much better outcomes. The other major outcome study was conducted by Rebecca McKeaton and colleagues, following up people with methamphetamine, so recruiting 360 people who are dependent on methamphetamine from Sydney and Brisbane, largely from detox and resi rehab settings, and then a control group of people not in treatment from the community. And I suppose Rebecca took a much more sort of hardline view of treatment outcomes in terms of looking at sort of continuous abstinence, so a really sort of hard measure of treatment success. And what you can see there in the bar graphs, I think at the end, is the top one is no treatment, the middle one is detox, and the bottom one was resi rehab. And so the top bar, the black, means you're using 3 or more days in a week. And then the next bar under that is 1 to 2 days a week. And then less than weekly is the white bar, and the grey bar at the bottom is no use. So what you can see there is at 3-month time point, the people in the resi rehab were doing the best. There was no difference in terms of absolute abstinence of people who've gone through detox. And by the end of 3 years, what you can see is the people in the resi group were more likely to be abstinent. But without even just eyeballing that, you can see, the percentage of people who are in the black, sort of right at the baseline compared to the end, is significantly decreased. So overall, people who've had some form of treatment in this sample did improve and were maybe not be abstinent, but much more likely to be using less. But what's interesting is they found that in terms of continuous abstinence, and I'll come back to these figures later, it's around a third at 3 months, 40% at 1 year, and 6% at 3 years. So around 40%. But that's continuous abstinence. That's not to say people didn't reduce their use. The final treatment outcome study is a study we did for the Commonwealth Government a few years ago, recruiting 790 people from 21 services in both Victoria and WA. People recruited from resi rehab, from detox settings, and from outpatient services. A lot of people in this group look very like the people we see in treatment here, so about majority male, mean age 36 years, only 30% in paid employment, 85% on benefits, 30% with legal problems, 25% homeless, and the primary drug of concern would be alcohol, about 47%, followed by methamphetamine at about 20%, and then looking at opioids at 15%. But the important thing to say about this sample is about 2/3 also had a secondary drug of concern, so not only the primary drug of concern, but secondary drug of concern, and about 1/3 had 3 drugs of concern, so polydrug use, sort of a major issue in this sample. We were able to successfully follow up about 73% of the sample, so 70% of them were re-interviewed, and the important thing to say is, 2/3, 70% reported that they were satisfied with the treatment that they received. If we look at sort of outcomes, what you can see there in terms of completion of treatment from when we recruited them, from their primary index treatment. So obviously we're very good at withdrawal, so we get 86% of people completing withdrawal, about 60% for resi rehab, and then in terms of outpatient treatment, which we might talk about, around about 60%. And if you look at the duration of treatment, again, we have a very sort of structured model here, was around, on average, is about 7 to 10 days in detox. On average, about 70 days in resi rehab, but 70 days in outpatient treatment as well. So again, it speaks to, I suppose, sort of what our models of care are in this space. And as you can see, people are most satisfied with withdrawal. I suppose they know what they're going to get, and they generally do get that, and they seem quite satisfied. And then about 70% for resi rehab and about 60% for outpatient care. When we look at abstinence rates by the past month, what you can see is that for the primary drug of concern, which is in blue, and similarly for other drugs of concern, we see the greatest level of abstinence among those going through resi rehab. This is at the end of 12 months, who entered there in the first place, and around a similar amount, around 1/3 being abstinent from in the past month in the primary drug of concern if they've gone through detox and outpatient services. So overall, about 1/3 abstinent in the past months after 12 months of going through treatment. The important thing to say, though, is we look at a measure of continuous abstinence. So this is just pure abstinence from the time they come into treatment. The figure is very similar to the one that Rebecca found for MAID. So it's about 14% of the sample at 12 months have continuous abstinence from the primary drug of concern. But the important thing to say is, obviously, treatment is not just about abstinence. So, one of the things we looked at sort of defined sort of a measure of treatment success. So there's a statistically significant reduction in the amount of drugs you were using based on when you came into treatment. And based on sort of that figure, what you can see is a much greater treatment success across the population. So in the black bars, we see treatment success, in the grey bars, abstinence from your primary drug of concern, and in the white bars, abstinence from all drugs of concern. And what you can see, which is sort of different to what's portrayed in the media, is that, the best sort of outcomes in terms of abstinence around methamphetamine, about 60%, followed by opioids, about 45%, cannabis about a third, and then alcohol. Alcohol, as we know, is one of the hardest sort of addictions to treat, around about 28%. If we include, though, those people lost to follow-up, so these are the outcomes for people, the 70% that I talked about that we followed up. But if we assume that all the people we couldn't follow up had relapsed, that's why we couldn't follow them up. So if we're much more conservative, what we can see is around overall in the sample, it's about 40% of the total sample have treatment success, or about 40% of the people we see have treatment success at the end of 12 months, and about 27%, so about a quarter are abstinent at 1 year. In terms of other domains, so if we look at quality of life from baseline to 12 months, we see a massive improvement across all those domains in terms of physical health, mental health, social circumstances, sort of the environment in which they live. And in terms of other function outcomes, we see, improvement in terms of reduction on people who are on unemployment benefits, and also sort of less likely of being sort of homeless or evicted. So improvements in those functional outcomes. And in terms of service use, so this is a really important point. If we go to a Royal Commission and we talk about the impact of alcohol and drugs, on the broader health system, certainly, so when we look at the year prior to when they came to treatment to the year post, while they've been in treatment, what we can see is they're less likely to use sort of acute withdrawal services, more likely to be in sort of resi rehab services, more likely to be engaged in mutual aid or other support groups, and much more likely to be engaged with other community services, particularly with primary care. So we're doing a good job at linking people up with primary care. But importantly, there's a reduction in use of ambulance presentations and presentations to ED. So, really important cost benefits to the broader health system in terms of treatment outcomes that we find. So I think the evidence, both from what we see in Australia, but also internationally, is that, once people are in treatment, most people show significant reductions. We also see improvements across a whole range of other indicators, such as health, offending, risk-taking, substance use and social functioning. And some of the estimates that have been looked at overseas shows that for every sort of dollar you put in, there's a $2.5 in terms of savings in terms of health and social care relative to treatment costs. So I think we've established that treatment works. So the next question is, which bits of treatment sort of has evidence to support that? So the areas that we found that sort of had the greatest level of evidence, and I'll go through these in a bit more detail, is withdrawal, rehab, supported housing, assertive outreach, care and recovery coordination, pharmacotherapy, psychosocial interventions, aftercare and peer support, and family support. So in terms of rehab, obviously you can care in different settings. Most of the evidence is focusing, in this state we have a whole range of outpatient sort of day programs. The literature on that internationally, there isn't much literature at all on the effectiveness of that. Most of the programs where the literature is based on resi rehab. So that's an area we need to really build up our evidence base, because it's certainly, we feel, an important sort of addition to the treatment system, but we certainly need to build that evidence. And most of the therapeutic models are around a 12-step model, a therapeutic community or CBT based. And the important thing to say about most of these reviews, the effectiveness of resi rehabs, most of them have looked at therapeutic communities, is that they found significant reductions in a whole range of issues and improvements in terms of functioning and employment and legal outcomes, but length of stay is really important. So people need to stay really, the evidence shows staying 3 months or longer is most beneficial. But the most important thing is that when you leave, you leave and you participate in subsequent aftercare. So if you just go and leave, it's not rocket science that, you're more likely to fall over. So having that set up and having that important aftercare is really critical in terms of success of those programs. And I think that's an issue because I think particularly how services are funded, services don't tend to be funded for that aftercare component. They tend to fund it for the episode, and then you go and that's one of the challenges is how we think we build this effective treatment system. So in that space, there is very good evidence internationally around the idea of supported housing, so that when people finish having treatment, they need to step down and perhaps need more support in the community that isn't sort of an acute sort of treatment setting. So supported housing has a lot of evidence overseas in terms of improving a whole range of sort of outcomes and increasing the likelihood of recovery. So really important in that space. I think in Victoria, Shark run a couple of houses, Oxford houses, that sort of run on a very sort of on a shoestring basically. But despite the evidence we have overseas, there's the struggle to actually get these forms of support actually funded. In terms of particularly, and I'll talk a bit later about the different sort of levels of complexity, but particularly for those populations who have significant sort of mental health issues as well as alcohol and drug issues, sort of the importance of assertive outreach has got an overwhelming evidence that, rather than waiting for people to come to us in our office-based settings, going out to people who often have multiple morbidities and are chaotic and sort of engaging them in small specialized teams with a small caseload has overwhelming evidence that leads to improved outcomes. Again, that's something, that with recommissioning, we've seen sort of the loss of the ability to assertively outreach, and particularly we're all aware of particularly subpopulations we deal with who really struggle to fit into the office-based sort of model which we now run. And so certainly in an effective system, we need to really think about how do we bring in that assertive component. Again, many of the clients that we see have a whole range of morbidities and other issues and often have to navigate and deal with multiple services. So there's a very strong evidence that, coordinated care or case management or has various different names, that coordinating that delivery of individual services from multiple sectors for the individual who sort of helps that person navigate and that system is incredibly beneficial. It's been shown not only to sort of improve sort of health outcomes, but also to improve quality of life and reduce the likelihood that people are going to attend hospital. So it actually reduces the burden on acute services as well. So a really important component. Pharmacotherapy, so there's overwhelming evidence, obviously, for the effectiveness of opiate substitution treatment, and also strong evidence that medications for alcohol dependence, like acamprosate and naltrexone, are affected. Very limited evidence at the moment around methamphetamine treatments. But the important thing is all these studies where they've been looked at have all been tested in the context of adjunctive psychological interventions and support. And, they have overwhelming evidence, but often the way that they're implemented sort of, I suppose, within health systems or, within different jurisdictions is generally what we're just doing is giving people scripts. We're not actually giving them the actual psychological component to go along with that. So again, particularly in Victoria, the overwhelming, I suppose, medical support for people with addiction is largely within primary care, which we know sort of has very mixed views of whether they want to manage the population or not. And we know there's very low prescriptions for alcohol pharmacotherapies and small numbers of pockets of GPs who want to do OSD. So there is a big issue, and we need to think about if we're having this system sort of, and I'll talk about it a bit later, it's how do we ensure that we have this element of the treatment system robustly supported. In terms of psychosocial interventions, there's a whole range of psychosocial interventions that have been shown to be evidence-based in this space. But the really important thing to say about this is that in terms of ensuring the effectiveness of the interventions, we have to have the right staff who are skilled and supported to deliver this, and with the right level of organisational support. And I think one of the studies that Kate Hall led, a big systematic review of the evidence base around motivational interviewing. So motivational interviewing, one of the sort of core psychological interventions that we offer within the alcohol drug sector. This is a study looking at all studies that looked at training people to become competent and MI practitioners. And essentially, we set a level of around 75% for people to score on to have that people had to reach 75% proficiency of a beginner level to be able to deliver MI training. And what we found in this study is there's not many studies that have looked at this, but essentially it's very hard to get people up to beginner proficiency. And there were studies that were able to do that. We're talking about doing, workshops and regular supervision, So, we need to think about if we've got evidence-based treatments and we're mandating that that's part of the treatment system, then we've got to actually resource the system to actually have the right staff delivering them with the right level of training, supervision and support. Otherwise, we're not really delivering it. We might say we're delivering it, but we're not delivering it to the high standard that we know the evidence suggests we need to. The other strong sort of component of the treatment system is around aftercare, peer support, mutual aid. So we know that, once people have gone through the treatment system, stepping down into something that is much more supportive, something that can provide a whole range of different support options is really important. Be that, stepping down to lower cost sort of distance-based interventions like telephone or online support, or linkage with a peer support or community group is really important. There's overwhelming evidence about the effectiveness of AA, including evidence of dose response and a temporal relationship, so attending being predictive of abstinence. Yet, we still have, I would say in this state in Australia more broadly, a sort of a healthy antagonism towards, or maybe unhealthy antagonism toward AA and mutual aid. So there's a whole sort of misunderstanding of the importance. So whether it's AA, NA, Smart Recovery, other community groups, overwhelming evidence that linking people, to other sort of peer supports and networks that model behaviours, values, attitudes, identities that sort of are really promote recovery are critically important. So really important that we think about how we link to these supports, which are essentially free. So in patient pathways, we looked at sort of engagement in mutual aid and looked at sort of relationship to outcomes. And certainly what we found is your treatment success, particularly if you had an alcohol problem, was very much predicated on how many mutual aid sessions you actually attended. So for those people, as you can see, who actually attended, essentially more than monthly. So we're not talking about, going every day, just attending more than monthly. You can see almost 65%, sort of had a treatment success. We don't see that same effect with illicit drugs. That's probably because with illicit drugs, it's much easier to move away from social networks that are using, or relatively more easy than with alcohol. Because with alcohol, alcohol's everywhere. And so to find a group of supportive peers who aren't drinking, there's not many settings in which that occurs. And that's where I think sort of mutual aid groups like AA, really provide a really valuable support, or other supports around that. But the evidence also shows that, what we do currently is not very helpful. So if I suppose the left-hand side of this slide is what our current practice is. So we identify people who have a problem, we tell them that they should go to AA, and we might even give them a phone number or a website to look at, and then, not surprisingly, most people don't come. Whereas what we know, Vic Manning and other people have developed sort of, there's a whole range of evidence around how we think about assertive linkage. So how we engage peers to assertively link to groups and help people to take to groups. So if we can actually get somebody to actually make contact, agree to take them to a group, we almost get 100% attendance. So thinking about if this is a really important aftercare program post-treatment, we need to think about how do we do that effectively and how do we build that into the system. Family support. So, the evidence shows us 3 types of interventions for families. So working with family members to promote entry and maintenance of treatment, so for the client you're working with. Then joint involvement, working with family members and clients both together in treatment. And then interventions that just focus on families themselves, around response to the needs themselves. So there's robust evidence that working with family members can trigger entry to treatment, and having families involved can be really effective. But the problem is that, as we know, with sort of privacy and a whole range of other concerns, often there's a reluctance to include or share with family members. And, I think, given the evidence around how important family are, and families are big sports, we need to think about how we more effectively do that. And interventions addressing problems caused by family members, they're often the main sort of carers and supporters. It's really important that we keep them healthy. And so interventions targeting family members are a really important thing, I think, as part of a treatment system. We need to think about how we focus in supporting family members. We recently did a study looking at families' experiences, so people ringing direct line and the ICE advice line, sort of trying to get experiences of what it was like for them, sort of looking after somebody, a loved one with alcohol and drug problems, and talking about sort of how, what factors promoted or sort of hindered help seeking. And really the themes that came up is that, like for clients ourselves, stigma is a really important issue for family members. They don't feel like they can talk to anybody else. They find it really difficult to navigate the system. They're not sure how to enter the system, who to talk to, how to navigate it. And when they do find a system, they find that it's very difficult for people to actually talk to them. They find that if they had a previous negative experience, that makes them more reluctant to seek help in the future. They often feel overwhelmed that, because they don't have many supports, they don't know who to talk to, they often feel hopeless, and so that stops them from seeking help. And often when they do access treatment, they often feel that they're excluded from treatment of their loved one. So they feel undervalued, and they feel not important, and they feel that, that's a real barrier for thinking about how to help their loved one. And in terms of facilitators, having good experiences predicts future help seeking. Being able to sort of work with a family member to sort of be able to allow them to be open with other significant others so they can get support is really critical in overcoming shame and stigma. And, the importance of sort of persevering. So I talked a bit there around the evidence around that treatment works, and that we have sort of certainly building blocks that are currently funded in this system that we know has evidence around them. So what are the factors? So we would just provide that, what are the factors that mean whether people are more or less likely to respond, to those services if we offer them? So there's three broad, I would say, factors that influence treatment outcomes. The first is individual factors. So obviously people with mental health or psychiatric issues, or people with problems with social stability, being homeless, unemployed, key individual factors that affect treatment outcomes, and I'll talk a bit about that. There's illness factors, so prior treatment history, the severity of your sort of addiction history and your dependence is a big key factor. And there's a whole range of factors in treatment itself in how we offer it. So in terms of how we build our therapeutic alliance, sort of how people experience treatment, how satisfied they are with treatment, how long we can keep people in treatment, and that sort of nature of continuity of care, how we sort of make sure treatment isn't fragmented. So we know from people we see that up to 75% of people we see coming through treatment services have a comorbid mental health issue, and we also know that having a co-occurring condition means that your drug use and a range of other outcomes are likely to be much more poor, and you tend to do much poorer in the treatment system. In terms of social stability factors, in people we saw coming through patient pathways, high rates of homelessness, unemployment. People who were unemployed were much more likely to have much more multiple ED presentations, much more likely, if they're homeless, also to present to ED. And people who were homeless had a much lower completion rate in treatment. So these factors are really important in terms of how they navigate and use and how we keep them in treatment. We know that past treatment is common. So in terms of patient pathways, even though we were recruiting people new to treatment, in terms of we were recruiting people who hadn't had treatment in the last month or more, 70% had been in the treatment system before. So it's really common for people to have a past treatment history. And those people, with higher rates of dependence and other complexities, if they're coming into the system, they're much more likely to have a much stronger and longer drug history than those who are new to treatment. And treatment history in our range of studies has been found to influence treatment outcomes. So if we're seeing people, I suppose this what I'm trying to present is, when we think about nuancing the treatment system, if we know what factors make people less likely to do well, we need to think about how to nuance our service offerings for those different subgroups. So treatment history is a really important factor. And there's overwhelming evidence that severity dependence is one of the best predictors of poor treatment outcomes. So obviously, like in any condition, the worse your condition, the more likely is that you're going to have worse treatment outcomes. There's over 1,000 studies showing that therapeutic alliance is one of the best predictors of treatment outcome. And particularly therapeutic alliance in the early stages of treatment is a really strong predictor of engagement and retention in treatment. In terms of treatment duration, in terms of pharmacotherapy, being on it longer is really important. So great evidence for the longer you can be on OST, the better. So it's not about getting on, stabilising, getting off. Length of stays, as I said before, has been a very strong predictor of treatment outcomes in residential settings. But it's really important to say that when we're saying we're keeping people in treatment, often we talk about we just need to keep people in treatment, and that's not a predictor of good outcomes, just keeping people in treatment. It's about us doing active things with people in treatment, not just holding on to them. And when you look at that treatment outcome research, it shows that the first 3 months are really critical. So you see most of those changes occurring in the first 3 months. So if you're seeing somebody and working with somebody and nothing's happening in that 3 months, then maybe it's about thinking about another approach rather than just sitting there and hoping that something's going to happen. As I said, when we look at that idea of treatment stability, continuity of care is the key, But we're often funded as an acute care model. We're providing episodic treatment. But, what we found was that, through patient pathways, was that engagement in ongoing treatment is a major predictor of treatment success. And particularly for illicit drug use and, engagement with primary care, GP, mutual aid, strong predictor for alcohol dependence. Those clients who didn't receive care coordination, so those clients who didn't get case management in that way, perceived the system as really complex and difficult to navigate. And while most people didn't get any follow-up, when they did get follow-up, even if it was just a phone call, they regarded that as welcome and beneficial, particularly if they didn't have strong social capital or family support. So it just speaks to the issue around how we plan. So often we plan in our service system, we're all funded on drug treatment activity units, so we're just thinking about single episodes of care, whereas really we need to be thinking about the journey and how different people are supported across that journey. So how do we take all that information and how do we build it and help design an effective treatment system? So substantial evidence that the treatment works. However, we're treating a very complex problem, and the nature of alcohol and drugs is cyclical and, treatments and what we provide is episodic, fragmented and delivered in isolation. So we need to think about how to deliver that service system, as I say, that is not just continuing, but integrated and matches need to intervention. So again, in terms of thinking models of care, obviously people are very familiar with step care models. So the idea is that we offer people treatment and we step them up the more they need. And as they get well, we step them back down again. We don't often do that. We have a thresholding to get into treatment. Then we offer them everything. Then they go off and we don't offer them, anything afterwards. So it's about how do we step up and step down and how do we create a system that allows us to do that? What's really clear is our clients navigate multiple systems, and they have to navigate both the alcohol and drug system, so that's horizontal integration. So in the same system, they have to move between detox, outpatient, rehab, back again. So they have to move that way, and then they have to move vertically. So between alcohol and drugs, primary care, welfare services, tertiary services, there's a whole range of integration to think about. And I don't think our system really thinks about how we integrate in a way that really works. So how do we connect? We can't even connect the systems within our own system together very well. It's very hard for us to have conversations, within our consortiums, never mind outside of our consortiums. And Michael Savison in the audit did a fantastic review for the Department of Health, where we looked at what are the strategies that help around integrated care. And this paper's freely downloadable. So it's an open access journal if people are interested. But there's not that much evidence out there around empirically testing it. But there is, some good indicators of what helps. So there's things that funders can do in terms of investing, in actual integrated care. So thinking about how they invest in that, rather than telling us all the time we need to work with other sort of parts of the healthcare system and welfare system, they probably need to talk to each other as well. And, when you think about how we put sort of that integrated working within sort of the specifications of the funding agreements. And at an organisational level, it's very much about interagency relationships, being clear about common agency goals. So rather than just saying we want to work together, it's being absolutely clear about what are we trying to work together on and what are the KPIs around that and how we demonstrate that's happening and how do we monitor it. And obviously the issue of co-location, working in the same space and sort of bumping in and talking to each other sort of promotes that sort of integrated working. In terms of the service delivery level, so that's at the organisational level, so that's around training people in how we work together. It's about sort of having protocols around information sharing, which is still sort of a massive challenge. It's around shared case management. It's about how we sort of promote cross-referrals and setting up systems and processes around that. And it's about how to set up professional networks where people come together and share cases and talk to each other and sort of learn about the way in which each other works. And then at the sort of the clinical level, sort of the coalface with clients themselves, it's around how we screen for things that we're trying to do together and identifying that, how we do some joint care planning and how we have supervision, not just around our cases, but a supervision about how we're working together sort of in a proactive way. So there's lots of things we can do around integration. I don't think we're doing much of it, but I think that's something we need to strongly advocate about. The other thing that we need to talk about is when we're developing this system is that, all the people that I suppose I've talked about today are people who are in the system. And, one of the big challenges we have is what the public perception of addiction is. And because of that, only 20% of people with, significant, alcohol drug use issues actually present for treatment. So we've got a major sales issue. If we were running an organisation and selling something and less than 20% of people wanting to come and use our services, then, we'd probably be rapidly out of business. So we need to think about, how we start to engage and encourage people to enter treatment and what that might be about. When we look at the evidence around barriers to care, so, this is broadly in the healthcare system. So, the moral model remains pervasive. People have very nihilistic beliefs about treatment outcome, even though I showed before that we have some really good outcomes in a whole range of different domains. The general public, largely through sort of what the media tells them, still believes that if you've got a drug issue, you've got no future. So we've got a whole marketing campaign to think about in terms of how we change those beliefs. And so because of that stigma, that's often internalized, so people blame themselves, and so they don't think they're worthy of treatment or treatment doesn't work. And there's all these concerns about privacy. In the primary care sector, we did this review for one of the PHNs. So one of the things that comes very strongly from GPs in the primary care sector is, they don't have time to sort of see this client group. They have the whole very strong community sort of stereotypes around this population. These patients are disruptive and they're manipulative and they're unreliable, they're complex. If I open my door and say I see people who have alcohol and drug problems, I'll be overwhelmed with demand. It's not really our job, it's somebody else's job. If I actually raise issues about alcohol and drug issues, that's going to threaten our relationship. So that's going to take more time and cause more problems and conflict. I haven't really been trained in this and I don't know where really to get support. So there's a huge, I suppose, in discussions with PHNs, there's a huge bit of work the PHNs can do around how we actively support primary care to sort of change some of their attitudes and views and actually think about how we actively support them. And the views of the alcohol and drug system, this isn't our views, this is views from primary care, is it's different to other areas of health. So in other areas of health, there's sort of clearer, the pathways for referral are sort of more consistent, whereas with ours, it's different numbers, different rules. It's hard, so I haven't got time to get my head around how we do it. It's difficult to navigate. It's faceless. I don't know who you are when I refer you. A lot of how doctors operate is around relationships and knowing, who to send people to. But, we're asking people to send to a faceless system. They report that they get very little back. So it's very rare that they get sort of discharge summaries or reports back from agencies when they send people there. So they don't know what's happening to them. So they feel disengaged. This is, across the system. People aren't sure sort of because they're not getting anything back. They're not clear of how strong the efficacy of the system is. Is it successful? Is it effective? And, often, GPs like to talk to other doctors, and there's limited addiction specialists in Victoria to actually talk to and sort of think about sort of, how to support them in that way. So there's lots and lots of barriers to care that if we're honest about sort of making the system more effective, we've got to think about how we tackle that. But it's important to say, so, this is just data from Counselling Online, which is one of the online services that we run nationally. But, as opposed to the 70% of people who present in patient pathways before to treatment, here we have, almost 2/3 of people contacting the service, telephone online for the first time because, it's anonymous, people, they can reach out, people don't know who you are. So there are mechanisms and models where we can think about how we encourage people to access the system, but we need to think about what that system is rather than just funding different bits that don't actually link to each other. So once we design, this effective system, which I'll come back to, so how do we decide what gets what? So we know the sort of treatment we want to offer, but how do we decide who gets what? And one of the things that people are familiar with is that we've been sort of working on is a sort of demand-based model. And just want to sort of really make it clear, this is a population health planning model. This is not a clinical tool. This is about how we segment populations sort of, in large populations. And so what we can do is we can we can sort of segment the population into different tiers. So we can have people who are tier 1, who might be just using alcohol and drug use recreationally without any problems. Then we have tier 2 of those people who are using it in a risky way. Tier 3, those who develop dependence and a bit of complexity. Tier 4, they have much more complexity. And tier 5, they're much more complex. So we see as we go up the triangle, people are getting much more complex and severe in their alcohol and drug and other associated issues. And we've done a bit of work, with different agencies around trying to map the types of complexities we're looking at. So we're looking at poor mental health, sort of lack of meaningful activities, so employment or training, sort of housing instability, whether people are pregnant, whether they've got comorbid gambling problems, legal problems, whether they're having to look after children, whether they've got poor physical health. So, there's a lot of ways to refine this model, but essentially it's about how do we start defining what percentages in each group, and based on that, how much investment do we need to put in each group in providing different level of service input. And in an ideal model, you'd have the sort of bottom 3 tiers sort of managing primary care managing sort of up to dependence with no real complexity. That's what happens ideally in most countries. That's assuming your primary care system wants to see this patient group. And then you have, the alcohol and drug system working across the other tiers, and then you have sort of a more specialised system working and supporting the more complex. So that's ideally what we would look at, and we'd have investment and we'd be able to map who's in each area. So what we did for the Department of Health is that we sort of, and one of the caveats around this, I have to say, is they only wanted us to model what they currently fund. So, which is unfortunate. So we wanted to sort of think about and this is a bit of work they want to do so they could take it to So at the moment, they don't have anything to take to Treasury, essentially, to sort of say what is the gap between what we currently fund and what we would fund based on sort of an ideal model of care. And it's not saying that this is perfect, but based on the evidence and based on sort of how we tier and based on other a major national project, the Drug and Alcohol Clinical Care Pathway Packages Project, led by Alison Ritter, probably about 8 years ago, where they came up with a candidate model for essentially different care packages for different levels of complexity. We sort of put something together where we sort of identified as around 30% of people we're seeing sort of in that sort of, in an ideal world. This is not people we might be seeing now. This is when we map the population. There's about 30% of people fall in that dependence and one complexity factor, and this is what they should get. Bit of non-residential withdrawal, bit of counselling, bit of asserted linkage. About 45% in that population who need a bit more, so a bit more resi rehab, a bit more counselling, care recovery coordination, probably some therapeutic day programs, and then slightly more complex, getting more of everything can have access to resi rehab. So that's the sort of model that we built, that we sort of tested with a few experts on an advisory group. And really, it's not perfect, but the idea is that it's at least a model that they can then scale up based on population percentages to actually take to Treasury. And I can tell you the figure that they would take to Treasury based on this is a significantly higher number than what is currently funded. So it's a good start. If we got anywhere near that figure, we'd all be very happy. But I think one of the things, and we flagged it in the report, but it's an issue that I think is critically important, if there is going to be a Royal Commission, because when we talk about Tier 5, obviously Tier 5, encompasses a lot of complexity, and we already see a lot of complexity in the system. We already see people with comorbid mental health and a whole range of social issues. But within Tier 5, there's the really hard group, who might be at 10% of that group, who have really significant mental health issues, really significant forensic issues, really significant physical health and social issues. And, that's the formula we use for sort of working out how to treat them. We're still working on the answer, but we've got the formula right. And really, I think we can all agree that the current model of care is not fit for purpose. Like, we don't actually have a model of care for people who are really complex. And I think at the government level, there's a bit of, often a bit of denial that, we've got alcohol and drug treatment services, got mental health services, we have forensic services, we have welfare services. You guys just work it out together. You do a bit of that integrated stuff you were talking about, and you can work it out. But really, we're talking about a service model that is very different, to what we're offering currently. That it does involve, small teams, assertive case mix, different levels of sort of different staffing profiles. Because the model I've showed you before is essentially what we're suggesting here is we're increasing the level of treatment. We're increasing how much people get based on complexity. But once you get to a certain level, just throwing more stuff at people is not going to make a difference. What we have to throw is something that's quantifiably different and qualitatively different. So it's about, I think, with this Royal Commission coming, I think it's about thinking about how do we actually have a more effective sort of service system for those people that we struggle with, who often don't stay in our system or rebound in our system or create a lot of having in the system. And often the people are on the front page of the Herald Sun where people say, well, look at that person who's using drugs, that's what they're like, and that's why we shouldn't be funding them. So to summarise, I've told you a lot in 50 minutes. There's a lot of considerable evidence that alcohol treatment is effective. To maximise effective, we need to think about the range of factors we know that influences treatment outcomes, but constructing an effective treatment system requires a much more coordinated, inclusive and integrated response that provides continuity of care, number one, and then matches need to intervention and really successfully both engages family support, but also encompasses that whole aftercare and low-cost support. Thanks very much.